Thank you, Nicole, for that very kind introduction and for the invitation. Good afternoon, everyone. I'm particularly thrilled to speak today at this event hosted by the Botnar Institute in Basel, since I'm currently working at its sister institution at the Botnar Research Center in Oxford. So iron is a particularly critical nutrient during infancy. In infants, birth iron stores and dietary iron absorption need to cover high iron requirements for growth and expansion of red blood cell mass. And many infants don't cover these requirements, which places them at risk for iron deficiency. At 6 months, iron deficiency affects up to 15% of breastfed infants in high-income countries and up to 70% of infants in low-income countries. And this is important because iron deficiency during infancy can impair cognition and growth, and it may also impair adaptive immunity and vaccine response. My presentation has 2 parts. First, I'll talk about how we define the trajectory of iron depletion during early infancy using a novel stable iron isotope dilution method. And second, I'll talk about the effects of iron deficiency during infancy on adaptive immunity and vaccine response. The traditional method to measure iron absorption is to measure the tracer concentration after tracer administration to determine fractional iron absorption. We established a novel stable iron isotope dilution method where we turn this concept on its head, where we use iron of natural composition acting as a tracer, diluting an ad hoc modified isotopic signature obtained via stable isotope administration and equilibration with body iron. So let me briefly illustrate the principle of the traditional method to measure iron absorption, which involves the measurement of the isotope incorporation into red blood cells after an oral dose. So there are 4 naturally occurring stable iron isotopes. Iron 56 has the highest natural abundance, and iron 54, 57, and 58 have much lower natural abundances, and therefore we can use these stable isotopes for our studies. So participants consume a test meal containing the label, in this case iron 57. And fractional and total iron absorption is then calculated based on the shift in the iron isotopic ratios in blood sample taken 14 days after the tracer administration. In our current study, we use the isotope dilution to assess long-term iron absorption, losses, and gains. This method does not measure the iron absorption from a test meal, but it measures long-term iron absorption, losses, and gains over weeks and months. Let me explain you how this method works. After the tracer administration, we have an equilibration phase where the oral dose of iron 57 gradually distributes throughout all tissues, enriching body iron. And this phase is followed by the measurement phase, where the uniform isotopic enrichment is indicated by a linear slope of the natural logarithm of the tracer concentration in blood. So this subject received an oral iron tracer, and after the administration of the tracer, we had a sharp increase in the concentration, which was then followed by a sharp decrease of the tracer concentration in blood, due to the recycling of the iron from senescent red blood cells into other tissues. So this subject reached equilibration after 8 months. So this method is based on 2 principles. Absorption of iron of natural isotopic composition increases body iron, decreasing the ratio of iron 57 to body iron, but does not change the amount of iron 57. And loss of iron from the body produces a parallel decrease in the amounts of both 57 and iron of natural isotopic composition, but does not change the concentration of iron 57. So K-abs is the fraction of iron in the blood absorbed per unit of time, measured as the negative of the decrease in the ratio of tracer to natural blood iron over time, as shown over here. So the steeper the slope of K-abs, the greater the dilution of the tracer in blood by absorption of iron of natural composition. And the measurement of K-abs is completely independent and unbiased by inflammation and infection and other factors that potentially bias traditional biomarkers of iron. Let me briefly show you how we calculated iron absorbed, iron lost, and iron gained. So iron absorbed was calculated from K-abs and total body iron. Iron lost was calculated from K-loss and total body iron. And total body iron was calculated from circulating iron, tissue iron, and storage iron. And then iron gains was calculated from the difference between iron absorbed and iron lost. Because we wanted to study the first 6 months after birth, and because, as I just showed you, the equilibration phase takes 8 to 12 months, we needed the newborn to be born already enriched and equilibrated. Therefore, we administered a labeled test meal to pregnant women in their second trimester, and subsequently, placental iron transfer uniformly labeled the fetus. We studied 3 distinct groups of infants. 8 infants were fully breastfed, 7 infants were fully formula fed, and 8 infants received a mixed diet. We assessed infants at 2 days of age, 3 months, and 6 months of age. So the beauty of this method for pediatric studies is that it only requires a very small amount of whole blood, which can be obtained from a heel prick blood samples every couple of months, and we can study iron absorbed, lost, and gained in great detail. We did dietary assessment using food frequency questionnaires, and the women recorded the specific formula type and quantity given every week. All infants received high iron formula containing 1.2 milligrams of iron per 100 ml. Iron intake from breast milk was calculated based on the mean concentration of iron from 2 to 6 months of lactation of 0.35 milligrams per ml and an average volume of milk intake of 0.78 liters per day. For the mixed feeding group, the volume of formula given each day was subtracted from the 0.78 liters to estimate the quantity of breast milk consumed. So these are standard reference values we took from dietary reference books and from dietitians. We considered measuring breast milk intake using the deuterium method, but then in the end we decided against because this method is labor intensive and requires a lot of saliva samples from the infants. So now let me show you some results. These are examples showing that K-abs in the breastfed infant group is quite flat, and it is much steeper in the formula-fed infants and in the mixed feeding group. So the steeper the slope of K-abs, the greater the dilution of enriched body iron, the greater the amounts of absorbed iron. Here we have the iron balance from 0 to 6 months by feeding type. And as you can see from this table, the total iron intake in the breastfed infants was over 11 milligrams per day, and in contrast, it was 0.27 milligrams per day in the breastfed infants. Despite this, higher intakes in the formula-fed infants, bioavailability from infant formula was only 3.2% compared to 42% in the breastfed infants. As a result, the infants in the formula-fed group absorbed about 0.46 milligrams of iron per day, and the infants in the breastfed group absorbed about 0.13 milligrams per day. Because iron losses were roughly the same in both groups, the iron gains were about 10-fold higher in the formula-fed group compared to the breastfed group. So in formula-fed and mixed-fed infants, down here, iron absorbed exceeded iron lost, resulting in net iron gains. In contrast, in breastfed infants, iron absorbed just covered the basal losses, resulting in minimal gains. At 6 months of age, hemoglobin and total body iron were higher in the formula-fed infants compared to the breastfed infants or mixed-fed infants, and 4 of the infants in the exclusively breastfed group were anemic, and no infants in the formula-fed or mixed-fed groups were anemic. So these results show the dramatic differences in iron nutrition between breastfed infants and formula-fed infants. Formula-fed infants had median dietary iron intakes of about 40-fold higher than breastfed infants. Iron bioavailability from breast milk was nearly 10-fold higher than from formula. Formula-fed infants absorbed nearly 4-fold higher amounts of dietary iron than breastfed infants and significantly more than mixed-fed infants. In formula-fed and mixed-fed infants, about half of their iron requirement was covered by birth iron stores and about half by dietary iron. And fully breastfed infants needed to draw more iron from body iron stores to meet their iron requirements. So this was the first time that we directly measured iron absorbed, lost, and gained from birth to 6 months. And we estimated and compared long-term iron bioavailability from breastfed infants and formula-fed infants for the first time. We think this isotope dilution has great potential because it can quantify with high precision long-term iron absorption and describe the trajectory of iron depletion during infancy. This method could help define requirements and refine feeding practices to prevent iron deficiency and in infancy. Our findings argue for the new development of infant formula, which are better absorbed. Nearly all of the iron, more than 95%, was not absorbed, and high amounts of unabsorbed iron in the infant gut can lead to changes in the gut, a shift in the gut microbiome and gut inflammation. One approach to improve iron absorption from formula would be the combination of prebiotic fibers like GOS and iron, which we have shown previously to increase iron absorption. So now I'll come to the second part of my presentation, the effects of iron deficiency during infancy on adaptive immunity and vaccine response. As we have just seen in breastfed infants born to non-anemic mothers, iron absorbed just covered basal losses. Now, in many low and middle-income countries, women enter pregnancy already iron deficient, and then iron deficiency worsens over the course of pregnancy. Because of this, many infants are born with low birth iron stores, low birth weight, or preterm. Together with a large burden of infection and a poor weaning diet, these factors together lead to a persistent, profound iron deficiency at time of vaccination in many African infants. Vaccinating against pediatric infectious diseases saves 4 to 5 million lives each year, and millions more have been saved by COVID-19 and yellow fever vaccines. But these vaccines don't always work well. As dramatically shown by this child with severe measles, vaccines in low-income countries often fail, leaving 15 to 20% of fully vaccinated children unprotected. Because of this, 1.5 million die each year from vaccine-preventable diseases. Like pediatric vaccines, also adult vaccines don't always work well. For example, influenza and COVID-19 vaccines show variable efficacy and work less well in Africa. But why do these vaccines underperform in low-income countries? Iron deficiency is common at both ends of the life cycle when vaccines are vital. Recent evidence suggests that iron deficiency not only causes anemia, but also weakens adaptive immunity and vaccine response. During iron deficiency, low serum iron limits iron supply to the lymph nodes, and this then results in iron-deprived germinal centers, reduced plasma cell IgG production, reduced B cell numbers and function, and impaired T cell activation and proliferation. A recent report showed some first evidence that there might be a link between iron deficiency and adaptive immunity. These studies was based on multiple family members from 2 families in Kuwait and Saudi Arabia. Multiple family members repeatedly presented at the hospital since they had severe infections. And missense genetic analysis revealed a missense mutation in transferrin receptor 1. And this disrupts the transferrin receptor 1 endocytosis. TFR1-mediated iron endocytosis is essential for lymphocyte development and proliferation. So patients had normal numbers, but defective T and B cell proliferation, as well as impaired class switching needed for antibody production. And these impairments were rescued by provision of excess iron citrate ex vivo. In a series of in vitro and animal studies, we recently showed, together with the University of Oxford, that when immune cells are made iron deficient, they proliferate poorly and produce fewer antibodies. And giving the cells back iron allows them to function normally. The impaired vaccine response in iron deficiency was shown by a profoundly impaired B cell and neutralizing antibody response in iron deficient mice, and by sharply decreased vaccine-specific antibodies in iron-deficient piglets. In our recent human studies, we assessed whether iron-deficient Kenyan infants have a poor response to vaccines. We followed 573 infants from birth to 2 years. Infants received the polio, DTP, Haemophilus, and pneumococcal vaccines. We measured iron status at time of vaccination and vaccine response at 6 and 18 months. We performed logistic and linear regression analysis on seroconversion and antibody titers. We included known predictors of vaccine response into the models, such as birth weight, anthropometrics, sex, and maternal antibody titers. And as you can see from these 3 logistic regression analyses, anemic infants had 2 to 5 times the risk of being unprotected versus diphtheria, pneumococcus 19, and measles. And hemoglobin was a significant positive predictor of anti-diphtheria, anti-pertussis, and anti-pneumococcus 19 IgG at 18 months. We then repeated the analysis using soluble transferrin receptor as a measure for iron deficiency. So the higher soluble transferrin receptor, the worse the iron status. And as you can see from these 2 logistic regression analyses, iron-deficient infants had a higher risk of being unprotected versus diphtheria and pneumococcus 19. And soluble transferrin receptor predicted anti-pneumococcus and anti-polio IgG at 18 months and 24 weeks. So remarkably, anemia and hemoglobin was the strongest predictor of poor vaccine response to polio, diphtheria, and pertussis. And iron-deficient or anemic infants had 5 times the risk of measles vaccine failure and twice the risk of diphtheria vaccine failure, as shown in this child with severe diphtheria. We then assessed whether iron given at time of measles vaccination improves vaccine response. In this secondary analysis of a previous RTC, 127 infants received iron or no iron from 7 to 11 months of age. They all received the measles vaccine at 9 months, and we measured primary and secondary vaccine response. Infants receiving iron at time of vaccination had a better primary vaccine response. Infants in the iron group had higher anti-measles IgG, were better protected against measles, and not just the quantity, but also the quality of their antibodies was higher. We then assessed the effects of iron treatment on response to pediatric vaccines. In this RCT, 288 iron-deficient Kenyan infants were randomized to receive iron or no iron from age 6 to 24 weeks. All infants received rotavirus, polio, Haemophilus, DTP, and pneumococcal vaccines at 6 to 14 weeks, and we measured immune and vaccine response at 14 to 52 weeks. So we have just completed this trial, and the data is now being analyzed. To get a comprehensive understanding of the effects of iron on the immune system, we assess cell-mediated response by investigating activation and differentiation markers across immune cells. We assess antibody titers, and we assess the plasma protein, the O-link plasma protein profile, and we do an antiviral IgG repertoire measurement. In addition, we are also performing bulk RNA sequencing. So we only did a first preliminary analysis of the baseline data, and it looks like that low plasma iron at time of DTP vaccination predicts lower antipertussis IgG. We also looked at these same effects in adults, and we assessed the effects of iron treatment on response to yellow fever and COVID-19 vaccines in young Kenyan women. In this RCT, 112 iron-deficient women received intravenous iron or no iron 1 week before the yellow fever vaccination and the JEDOX COVID-19 vaccine. And we measured vaccine response at 1 and 2 months later. We have currently 4 running RCTs assessing the effect of iron depletion on vaccine response. In infants, we are assessing the effect of iron deficiency and iron treatment on the malaria and measles vaccine response. In adults, we are assessing the effects of fortification iron and oral iron supplementation on different types of vaccines. These studies are being done in Thailand and in Kenya. And then we have a mechanistic study where we use the human challenge model using the keyhole limpet hemocyanin to assess the effect of iron deficiency on immune response, and this study is being performed at the Botnar Institute in Oxford. So all these studies are going to be completed in 24 and 25, so we can expect some high-quality data soon. So what questions should be addressed in the future in the field of iron deficiency and adaptive immunity? How does iron deficiency influence proliferation and polarization of T and B cells? Does iron deficiency also affect immunity in barrier tissues like the gut and skin? Does chronic iron deficiency have long-term effects on the development of the immune system during childhood? Which vaccine types are more susceptible to affect iron deficiency? And what's the best timing and dose of iron to improve immunity? So growing evidence suggests that iron is critical for adaptive immunity and vaccine response. In iron-deficient infants and adults, iron may be a nutritional adjuvant to improve vaccine efficacy. And because iron deficiency is so common and the vaccine-preventable disease burden is so high, if iron improves vaccine efficacy even modestly, this would have major health benefits. So iron deficiency and vaccines are two priority areas of the Bill and Melinda Gates Foundation, And we were asked to present these results personally to Bill Gates at a meeting 2 years ago. I have to say it was a bit scary, but he showed real interest and asked some good questions. So with this, I'd like to acknowledge my colleagues at the University of Oxford, ETH Zurich, and the University Hospital in Zurich, and also my partners in low and middle-income countries like Kenya, Thailand, and Mexico, and of course the funders for the generous support. And thank you for your attention.